Good morning to everyone. My topic today is briefly summarized which progress in conservative therapy has been done in IBD patients. Sorry. My agenda consists with 5 points. Firstly, I would like to introduct IBD, the type of patients. It's very important, this budesonide story, I think, from clinical practice. I would like to mention a few words about biosimilars, especially biosimilar infliximab in clinical practice. And what about new biologics is focused on vedolizumab, and new approach how to patients monitor and stratify at the beginning. As you know, inflammatory bowel diseases is chronic inflammatory conditions involving GIT. It consists of 3 clinical entities. It's Crohn's disease, ulcerative colitis, and IBD, unclassified, involved large bowel. So this is a complex disease, meaning that inflammation involves small and large bowel, as well as some extraintestinal organs, in perianal lesions, and in some patients, some consequences, metabolic and septic complications appeared. The problem is that at the moment is currently incurable conditions, and we have a lot of drugs and not effective so much, and we use frequently surgery. We have a suboptimal efficacy of these drugs, including biologicals, and associated with the common side effects. If you mentioned about current medicament therapy in IBD patients, usually divides into 2 groups. The first one is conventional therapy, it's using in clinical practice, which is low cost, is easily available for everyone, and unfortunately associated with the less effectivity. The biological therapy started beginning in the millennium. It's a high-cost associated therapy. In some poor countries, including my side, Czech Republic, is restricted to access for that, and comparing to a conventional therapy associated with a higher effectivity. So this is a current approach in clinical practice. It's a current applied, it's a step-up therapy, meaning it's a gradually upside drugs started, mesalazine, mostly in patients with ulcerative colitis. In the severe diseases, steroids, it's a topical or systemic acting immunosuppressant, and the imagination in the top of the hypothetical pyramid is monoclonal antibodies, anti-TNF-alpha, infliximab, adalimumab, or golimumab. This is a usual approach named step up. In some patients with very negative prognostic factors, we used top-down or early accelerated step-up therapy, meaning those with a younger age, with a long involvement, small bowel perianal disease, for example, we start very early, after 2-3 months, steroid therapy failed, monoclonal therapy with the biological drugs. Firstly, I would like to mention budesonide story. As you know, the budesonide is unhalogenated steroids with a high affinity to corticosteroid receptor, which is completely reabsorbed for GIT, and with a high first pass effect due to liver is completely metabolized, and the systemic acting is quite low, the minimized side effect. As you know, it's a 20 years old history. At the moment, a couple last years, new innovations appeared in clinical practice. The first is 1 daily dose. Budesonide might be applied in Crohn's disease patients, or MMX budesonide applied in ulcerative colitis patients, or rectal foam for local therapy in UC patients with proctosigmoiditis. This is results of clinical trial compare efficacy, one daily dose, 9 milligrams budesonide versus budesonide 3 milligrams 3 times daily. And Axel Dignas showed that effectivity expressed by CDI is dramatically the same, and this side effect suppression for endogenous steroids is the same, and this is a clinical response is the same. We know that one daily dose, 9 milligrams budesonide applied as a sachet granulates, is the same effective as the budesonide 3 times daily. I think it's very important for clinical practice to improve adherence of patients to medicament therapy. It's a focus on Crohn's. It's a mild to moderate, especially in those in the ileocecal region. The second one, budesonide story, is budesonide MMX. This is a composed special matrix, hydrophilic, lipophilic matrix with the embedded particles of budesonide here. And this special composition, patented by company Cosmo, enabled to release budesonide just in large bowel. It's important. It's quite different from standard budesonide drugs using release budesonide in ileocecal region. It's a budesonide MMX release budesonide in the low large bowel. This is a scintigraphic proof. This is very important for patients with a mild to moderate ulcerative colitis patients. This is a Simon Travis paper published a couple of years ago, shows that 9 milligrams budesonide MMX once daily is more effective than placebo to achieve remission in those patients with a mild to moderate ulcerative colitis. In the clinical practice, the position budesonide MMX is between mesalazine and systemic steroids. Those patients fell to maximal dose of mesalazine should be switched with a mild to moderate activity, should be switched to budesonide MMX. And lastly, I would like to mention the budesonide story focused on proctosigmoiditis using budesonide 2 milligrams as a rectal foam. It's very important. Professor Gross showed that effectivity to local therapy with proctosigmoiditis, its enema is the same level as foam. But if you ask patients what prefer, is that most of them, 85% prefer foam because much higher tolerate, much easy to use. It's very important to improve clinical practice and tolerability of patients. Now I would like to mention a few words about the hot topic is biosimilar infliximab in naive or in the switch patients, including my personal experience. As you know, biosimilar infliximab has been approved by EMA from clinical use. It's the 27th June 2013. And before that, in preclinical studies proved that primary and secondary mechanisms of action is quite similar or quite same as original infliximab, including many others. Some differences exist, of course, for example, fucosylations, and this introduction of biosimilar infliximab has been associated with the concerns and fears about activity, effectivity, and side effect, including immunogenicity. I would like to show you my experience or my side experience. It's 120 patients, naive patients, Crohn's and colitis, which have been indicated for biological therapy. As you know, after 38 weeks if therapy started, it's a standard regimen, 5 milligrams per kick, 0, 2, and 6 weeks. After that, maintenance therapy every 8 weeks. You can see that in 38 weeks after biosimilar infliximab introduction, this is a positive response in Crohn's disease patients in 85%. In the ulcerative colitis patients, it's a positive response in 65%. If you remember, this is the same level in the original infliximab. This is a what about mucosal healing? It's a focus on cohort of ulcerative colitis patients. You can see this is a potent drug to induce mucosal healing. It's the same range as original molecule. You can see this is a MYO3. It's a predominant involvement in the rectum or rectosigmoidum colon if the biosimilar infliximab starts. You can see here this is a mucosal healing in the term of MYO0 or MYO1 is perhaps 50%. If you remember the clinical trials, Act 1 or Act 2, it's the same level. I would like to stress that the mucosal healing is a short period, is the same as the original molecule. And we have some experience with the switch patients. We have a cohort of 74 patients on long-term therapy. It's the original infliximab. At the beginning of last year, these 70 consecutive patients have been switched to biosimilar infliximab. What happened after that? You can see that nothing, because this is a blue color, is a clinical effect. It's a still remain in the complete remission there in ulcerative colitis patients, Crohn's disease patients expressed by Wormsley or Harvey-Bradshaw score. This is a difference is a 0. You can see that this switch patient is very, from clinical point of view, is very clear safety. It's the same efficacy as original molecule. This is a little bit complicated. It's a busy slide. Showed that what happened after switch of patients with the maintenance therapy by biosimilar infliximab. You can see that C-reactive protein, the mean value is the same over time, 56 weeks. What happened with the fecal calprotectin after the switch is the same after 56 of switch. What about the trough level infliximab is significantly appeared due to intensification, because not involved by drugs. It's our activity because we applied in clinical practice therapeutic drug monitoring and increase to keep its normal range between 3 to 7 micrograms per milliliter. You can see here that production of antidrugs antibodies is quite low in our cohort of patients, at only 10% of them. I would like to stress that my experience is that this biosimilar infliximab is potent therapy, is the same effective as original molecule, and the switch from original to biosimilar is associated with no negative signals or side effects, and immunogenicity seems to be same. The new biological drugs in IBD, a lot of work will be done about vedolizumab. What is it? Vedolizumab is humanized IgG1 antibodies against alpha-4 beta-7 integrins expressed on the surface of activated lymphocytes, and the blocks to trafficking of activated leukocytes from vessels to tissue and improve inflammation. We have very positive results, especially in those patients with ulcerative colitis. The Gemini 1 project showing that very high clinical remission, especially in those patients with the maintenance therapy. It's the biggest results from all biologicals we have. We know that vedolizumab is also potent therapy in Crohn's disease patients, but this is a long-term latent period. We have to apply 3 or 4 induction infusion. What about position vedolizumab in clinical practice? We are already started in the Czech Republic, and unfortunately this time is not on the market yet, but we expect it very, very soon. If you look at ulcerative colitis patients, it's indications of infliximab or adalimumab as well as vedolizumab in those patients with a chronic active course of disease and corticosteroid dependent seems to be optimal indications to start therapy with the vedolizumab. We know that those patients with the acute or acute severe colitis, so-called fulminant colitis, probably is not role for vedolizumab because latent period for 6 weeks we have to await to achieve clinical response. I think this is absolutely role for infliximab. And in Crohn's disease patients may be used as a second line therapy in those patients failed to anti-TNF alpha monoclonal antibodies. We have no data about efficacy of vedolizumab in those patients with the periannular disease. Probably not this optimal topic for that. And we will try in the clinical practice to get a lot experience. And lastly, I would like to mention the new approach to IBD patients based on stratifications and monitoring. Firstly is very important for clinical practice for us to stratify every patient at the beginning of the diagnosis and select patients with negative prognostic factors, including, especially the Crohn's, including young patients with the diagnosis, with the long involvement, especially small bowel. It's a periannual disease involvement in the time of diagnosis. It should be considered, keep in mind that accelerated step-up therapy is needed in those patients because loss of time and chief complications. In patients with ulcerative colitis, it's a negative prognostic factors in the time of diagnosis is, of course, young age of the diagnosis, extensive colitis, and need steroid therapy at the start. It's very important. We have some risk matrix model. For example, this is a very nice paper published by Milada Čvančarová a couple years ago, using those in UC patients as a risk for colectomy after diagnosis. She used inflammatory markers, sedimentation rate, age of diagnosis, involvement of large bowel at time of diagnosis, and the steroid at the time of diagnosis. In those patients, with a younger age, with extensive colitis, with severe inflammatory markers, maybe sedimentation rates of erythrocytes or CRP, and needed to be treated by steroids, this is a 15 times risk for colectomy. I think it will be fine to use some like this model for stratification and the diagnosis. The second news how to change approach to IBD patients is therapeutic drugs monitoring. I think it's a role for biologics. We know that patients on biologic therapy, loss of response. In the first years of period of therapy, 25 and 30% patients loss of response, and every other year we lost 10–15% of them. The reason might be metabolization, losing of drugs, and not effective therapy. And we would like to keep trough level, is the availability of the drug in the blood before next infusion in the optimal range. The optimal range was estimated between 3 to 7 microgram per milliliter. This is some controversial, but I think this is a therapeutic drug monitoring on biological therapy usually, mostly, has been applied in clinical practice. It is a TAXI trial. The secondary results are very important, showing us that those patients will be monitored based only in the clinical symptoms. It's different from those monitoring by therapeutic drugs monitoring, showing this a difference for needed to rescue therapy. I think this is very, very important for clinical practice, how to keep for long-term a sustained effect of biological therapy in the future. Ladies and gentlemen, I would like to summarize firstly that conventional therapy including budesonide aminosalicylates, change. In the last couple of years, the aim of the change is improve adherence to medicament therapy, minimize side effects, of course, and improve efficacy and tolerability of these patients. Introduction of biosimilar infliximab is the most important achievement is that significantly reduced cost and increased availability of biological therapy, especially in the poor countries, European poor countries, and a higher proportion of patients have access to biological therapy. It's very important. New biological drugs, including anti-integrins, vedolizumab, was introduced in the market in the last year, and we have to find optimal position in clinical practice. And lastly, a new approach, including strict patient stratification at time of diagnosis and therapeutic drugs monitoring, especially in those of biological therapy, has been already utilized in clinical practice. Thank you for attention.